this is HIFU is now coming as a office practice in many centers across US, UK, and this paper revolves around this. It's 15 years experience. And basically, we are all aware about the standard treatment options in intermediate and high-risk patients. Initially, HIFU was only recommended for low-risk patients or very low-risk patients, and now it has been climbing the ladder as a replacement for active surveillance or as an alternative. And this paper mainly revolves around the data what they have accumulated in the registry in 13 centers in UK, and they have come up with the outcome measures. The objective is to have oncological outcomes and adverse effects following HIFU for a non-metastatic prostate cancer, especially intermediate and a high-risk disease. So they pulled out around 1,379 patients with at least 6 months of follow-up, and the HIFU machine used was sonoblade. Gleason score 6 to 9 prostate cancer patients were taken up, and few patients had stage 3 disease also. 1.5 to 3 Tesla MRI was used in this, and the indication was any MRI visible lesions, and the patient having no high volume disease in areas which cannot be treated by focal ablation. D-amico classification was used, and when the patient had an intermediate high-risk group disease, further imaging in terms of bone scan and cross-sectional imaging was done. Ablation was done with the help of MRI fusion or sometimes expert-guided visual estimation. And in this analysis, up to 2 sessions of focal therapy were allowed. And some cases where the operator felt that, okay, the disease is a high-volume disease and cannot wait up to full effect of HIFU to set in, then they were given neoadjuvant and an adjuvant hormonal therapy, especially within 12 months of the focal treatment. Protocol was as similar like what we do, like PSA every 3 to 6 months in first year and then 6 monthly. MRI was routinely done every 6 to 12 months. However, for cause MRI, as in if the patient has an elevated PSA, then it was indicated as and when required. And then subsequently biopsies were taken, and if the patient seems to have progressed or a new de novo disease happens, then a repeat focal treatment, that is a second treatment of HIFU was given, or a patient could have offer a treatment for radiotherapy or a radical prostatectomy. All adverse events were also identified. So outcome measurements was mainly in terms of failure-free survival, and secondary outcomes were mainly related to the retreatment-free survival, salvage, whole gland, either RP or RT free survival, ADT in those patients who were offered free survival, metastatic free survival, and prostate cancer specific survival. All the adverse events were reported as per Cleveland-Dindo classification. So if you see this, the mean PSA was 6.9, and the predominantly in this study, in this paper, the authors managed to pull up more of an intermediate and a high-risk group disease patients, which accumulated around 93% of the total population. And if you see the last paragraph, then the predominant accumulation happened from 2010 to 2020. So last 10 years, 10 to 12 years, they were able to accumulate these patients because then they were including more intermediate and high-risk group patients. So, sorry, couldn't pull out much of the table, so this is what I have been given. So, the Kaplan-Meier estimation for failure-free survival, that is the primary outcome, was, if you see in all risk group, it is 69%. And if you see in intermediate and high risk group, so in intermediate, if you can appreciate the green curve, so it is 68% at 7 years. And the red curve, which is a high risk group, it is 65%. So definitely up to 70% we can take home that failure-free survival can be achieved with 2 sessions of HIFU. Similarly, if the patient progresses on the 2 sessions and then they have offered a salvage protocol in terms of either RP or RT, then subsequently we can still achieve a 70-73% failure-free survival after such treatments in both intermediate and high-risk group patients. Secondary outcomes, like I mentioned, so up to like it's already discussed that up to 75% at 7 years in those patients who had RP or RT, they have failure-free survival, and many patients were followed up to 5 years that comprises of around 75%, and still they were doing better with 2 sessions of focal therapy and didn't require any more treatment. If we pull out of 1,300 patients, 91 underwent the whole gland treatment, that is 53 were undergone RP, and 39 underwent RT. So up to 75% patients we can have a reasonable control of the cancer in both intermediate and high risk disease. The complications rate were also very less, where the reported complication was for Cleveland-Dindo more than 2 grade was just less than 0.5%. So at 7 years, if we take into the consideration, almost 69% patient has a failure-free survival with a primary focal HIFU therapy in a non-metastatic setting, with a metastatic free survival of 100% and prostate cancer specific free survival of 97%. 20% of the cases needed a second session of HIFU over 7 years, and second focal treatment appears to be effective and remains part of the focal therapy intervention. The patients are already counseled at the time of inclusion, when they were offered HIFU, that they might require at least 2 sessions, if not more. So this paper actually doesn't require any patient informed consent, because it is just pulled out of the registry, and ethical board approval is also not required for this paper. So there are strength in this paper is that predominantly almost 93% is a intermediate and a high risk disease, whereas the very few are the low risk group, and complications have been reported, which is it's 0.5%. I just missed the 0.0. And incidence of rectal injury and urinary retentions and UTI rates are also very low. The important part in this paper was that all patients undergoing HIFU were advised to do, were actually had a catheter for 7 to 10 days, and they were self-taught to have a self-intermittent catheterization, which on and off, if they have undergo a retention, they were supposed to do it. And a 7-day antibiotic protocol was followed. So that might also affect this low rates of retentions and UTIs. So limitation is there. The patient, the follow-up is quite low. The median follow-up is just 32 months, and sometimes patients may not are not willing to undergo a repeat biopsy if the PSA is remaining stable and non-suspicious MRI results are there. So this is always a risk and benefit when we offer this kind of treatment, because the whole crux of the treatment is the follow-up protocol, which if the patient doesn't comply, then it's a problem. Location of recurrence was not captured, which is very much important, whether the same area is recurring or because HIFU is normally practiced as a quadrant or a hemi-quadrant ablation therapy. So which part of the prostate, which quadrant is recurred was not mentioned here. And also the compliance with the patient-reported outcome measure score was very low in this. So whether patients were really happy, whether the retention and all part, they were really okay with the self-care and all, that were not reported properly. So in conclusion, HIFU seems to be a reasonable alternative to active surveillance, or maybe a form of a treatment in intermediate and high-risk cancer, in terms of having a good cancer control in medium term.